Hey team, welcome to the MMOA Podcast. I'm Macy Bolt, outpatient PT and TA with the Older Adult Division of ICE Physio. Today, we are going to break down a relatively new vestibular diagnosis that will help you better categorize those patients who don't seem to quite fit into some of our other vestibular buckets so that we can keep our dizzy folks moving. So the diagnosis we're talking about is Presbyvestibulopathy. We're going to call it PVP for ease. That's the one we're talking about today. And it was defined in 2019 in an effort to capture the age-related loss of vestibular function, similarly to other age-related losses like presbycusis and presbyopia, which are age-related hearing and vision loss. So this diagnosis was defined in an effort to really categorize that age-related vestibular loss. One important factor with all of these diagnoses is that they are all considered mild conditions. So folks who have these conditions are not completely deaf, blind, or experiencing complete vestibular loss, which is a really important distinction to make when we talk about the diagnostic criteria and also the differential diagnosis of this condition. So let's jump into the diagnostic criteria so that we know what to look for clinically. Agrawal and colleagues defined the diagnostic criteria for PVP as the following. There are 4 criteria. So number 1, a chronic condition lasting greater than 3 months with at least 2 of the following: postural imbalance or unsteadiness, and that can be static or dynamic; gait disturbance, and that could be disturbance in a manner of slowness or unsteadiness; chronic dizziness, that can be with head movement, walking, or in just an upright position; and recurrent falls, which they defined as more than 1 fall in a year period. So number 2 for the diagnostic criteria is a mild vestibular hypofunction, which they quantified by V-HIT testing, rotary chair, and caloric testing. And they defined a very specific range of values for all of those tests. We are not going to get into detail on that, but the purpose of defining that very specific range of values is to quantify the mild nature of the hypofunction, because if, like I mentioned before, if it becomes more severe than that, it would be more consistent with something like a complete vestibular loss. It is probably unlikely that as a clinician, you have easy access to testing like this in your clinic, but I would highly recommend find a great ENT and audiologist in your area that you can create a referral network with to be able to better serve these patients, because these tests can be very, very valuable for patients who their dizziness just isn't quite adding up or making sense. So that's my call to action, is find a good ENT and an audiologist that you can create that relationship with. So that's the second diagnostic criteria. Number 3 is that age has to be 60 years old or greater. And then number 4 is that it can't be accounted for by any other diagnosis or disease. So that means that this is a diagnosis of exclusion, meaning we have to be doing a really, really solid differential diagnosis before slapping a PVP diagnosis on someone. Okay, so to review those 4 diagnostic criteria. Number 1, chronic dizziness with 2 of the following: imbalance or unsteadiness, gait difficulty, chronic dizziness, and recurrent falls; a mild vestibular hypofunction, age greater than 60, and not better accounted for by a different diagnosis. So then when we think about doing that great differential diagnosis for PVP, we need to be considering all of the other things that we should be screening for. Not a complete list by any means, but some of the things we should be screening for are BPPV, unilateral hypofunctions, because this is a bilateral disorder; bilateral complete vestibular loss, BPD or visual vertigo; orthostasis; visual and proprioceptive impairments; polypharmacy; medication interactions; and normal pressure hydrocephalus. Like I said, that is by no means a comprehensive list of the things we should be screening for, but that is just kind of the beginning of other things that could present similarly to PVP, and we want to make sure that those things are not occurring if we're going to give someone a diagnosis of PVP. So I'm not going to get into how to test for all of those today, but if you're thinking about how do I even start screening for some of these things, a really general screen for vestibular conditions could look like a really good cervical spine exam, an oculomotor exam, testing cranial nerves, VOR testing, head impulse tests, Dix-Hallpike and horizontal roll testing for BPPV, and a modified CAT-SIB. That's a really good kind of sensory screening tool. So in an effort to rule out any other diagnoses, once you do your other testing, all of those things should come back relatively clear in the process of kind of screening for some of those other conditions, except you might see positive VOR testing, a positive head impulse test, and the modified CAT-SIB might be impaired. Those would likely be positive in the case of a mild hypofunction and postural imbalance, which are both two of the diagnostic criteria for PVP. Okay, that was a lot. So now we've talked about the diagnosis of the condition, how to make sure you are ruling out those other conditions that could be present. And so now, what the heck do we do with these folks? You're pretty confident that the patient in front of you has PVP. They've had the testing done. They fit the diagnostic criteria. And one thing that is really interesting about this condition is that it is pretty rare for PVP to present in isolation. So often these patients are going to come in with that gait instability, the frequent falls, and if you're seeing those things and it's just the vestibular component of it all that makes you a little uncomfy and a little leery, start with the gait and the falls portion. We all know how to make someone steadier on their feet and stronger throughout their body to make them a more resilient human. This is going to be incredibly impactful for someone with PVP too. When we lose vestibular function, even on a mild scale, that automatically means we are going to have to rely more on our visual and somatosensory systems to stay upright. So we need to make those systems bulletproof. Those systems cannot fail us if we have a vestibular system that is not functioning at its highest level, because that is going to be what we rely on in order to not fall and to keep our balance if we do lose our balance. So if you have been around with the older adult crew for a while, you know we love the idea of layering. So while you are working with that patient to get them stronger and fitter and steadier with their gait, add in some easy vestibular layers to what you're working on. People often overcomplicate this. It does not need to be complicated. In fact, many times my patients who have a vestibular disorder really just need to start moving their head again. At the beginning, I really am not concerned with how many head turns per minute they're doing, how long they're sustaining it for, or any of those kind of minute details that really do come into vestibular rehab. What I am most concerned with is that the patient decreases their fear and sensitivity around moving. If we have people who are afraid of moving, they are not going to move. And that is going to lead to more sedentary behavior, more deconditioning, and that is not going to be helpful for these folks. So what I'm training people to do at the beginning of a vestibular rehab course is move your head at a rate and at a duration that is relatively comfortable for you. You might get a little bit of symptom, but that symptom should come down pretty quickly once you stop moving your head. We want to keep these people under the threshold of severe discomfort. So if I'm working with a patient and they start moving their head and they're starting to feel a little unsteady, I might have them slow their head movement down. I might have them sit and move their head instead. There are a ton of ways that you can modify this while still getting people moving. So just a pro tip from someone who has treated a lot of dizzy people, there is no faster way to lose good patient rapport than to take someone who is super dizzy and unsteady and make them feel more dizzy and unsteady without a way to settle it down. So we need to know that we're staying within that symptom threshold that is going to keep them coming back. Because if they don't come back, we can't help them. Do not do that to your patients and do not do that to your therapeutic alliance, because we need these patients to buy in to what we're selling. And the way that we get them to buy into what we're selling is to make them feel more steady, make them feel safe, and make them feel that they have control over their symptoms and can calm things down when they need to. So once you get the patient's head moving, then you can add the other layers in, like disrupting their vision with sunglasses, goggles, dribbling goggles, and turning the lights off, having them close their eyes. The opportunities are endless there. And you can add somatosensory layers in by changing their shoe wear, having them take their shoes off, walking on a foam or a mat surface, taking them outside, walking on uneven ground. And if you're thinking, wow, I already do some of that stuff, yeah, it sounds an awful lot like how we treat a ton of our patients who already have frequent falls and gait problems, right? So you are already doing this. We just have to think of it in that layering aspect where we're really biasing the vestibular system for these folks specifically. Christina, who's one of our older adult leads, is well known for saying all therapists are pelvic health therapists, and I feel the exact same way about vestibular disorders. We are all treating the vestibular system, whether we know it or not. We just have to be a little more confident in our ability to do so in order to really bias that system to help our patients feel better. The more well-versed you are with vestibular content, the better clinician you can become and the better outcomes you're going to see with your folks. So when you get to clinic tomorrow, I want you to just look at your caseload. Do you have patients in front of you who are 60 plus, and for the last 3 months have felt chronically dizzy, unsteady, slow to move, and are falling? If so, you should be doing a vestibular screening exam on those folks to rule out any other diagnoses and potentially referring them for vestibular testing if warranted. Then you are going to treat them with a well-rounded balance, gait, and strength program to address their specific deficits and strengthen the vestibular system to help them improve their condition and improve their function overall, most importantly. You may not think that you are seeing PVP, but I am willing to bet that PVP is seeing you and you just have not identified it yet. Thank you so much for joining me today. And if you are looking for more ideas on layering and interventions with patients, join us at an upcoming live course or online course, which you can find at ptonice.com. Also, click the link below to receive our biweekly MMOA digest straight to your emails with tons of good clinical pearls and tidbits that you can take and really implement in your practice. Can't wait to connect soon.